Well, good morning, everyone. Morning. Wonderful to see so many people here on this glorious March morning at the Christie for this event, which is the third in the current series of these spotlight events, which are here to help just give you a bit of insight into some of the work that's being done at the Christie and funded by the Christie charity in the areas of research and treatment of cancer patients here at the Christie. So I'm delighted to say that I think this is a record number of registrations today, and I'm really pleased because we've got an absolutely fantastic panel of speakers ready to talk to you today and to take your questions. So there will be an opportunity for Q&A at the end, so please do be thinking of any questions that you'd like to ask, and we can address those at the end. So today we have Sara Valpione, who is a clinical medical oncologist here at the Christie, and she has a particular focus area on the upper gastrointestinal tract, so cancers of the mouth and the esophagus, and she does some incredible work just over the road in the Patterson that she's here to talk about today. We also have Dr Emma Searle, who is a consultant haematologist here at the Christie, and she's got a focus area on early stage trials to help detect and treat blood cancers. So I believe that she's got some really interesting results from a new drug, which we like new drugs here at the Christie, and this one is to help treat myeloma. There we go, myeloma. So we're looking forward to hearing from Emma. And then the climax of the event will be hearing from our patient, John McGartland, who has benefited directly from being part of a clinical trial here at the Christie, and we're really looking forward to hearing his story. So I will now hand over to Sara. Thank you.
Can you hear me without the microphone?
Yes.
Better. So thank you for the kind introduction. I'm Sara Valpione, a medical oncologist at Christie and also an academic. I'm a bit of a hybrid because I take care of patients, but I also spend a lot of time in the lab, where I try to understand why things do not go as we want in some of our patients. And as Bod mentioned, I'm a specialist of the upper part of the digestive system. So the esophagus, which is the tube that brings your food down after you finish to chew it, and the stomach, where the food stays when it's being digested. And the tumors of these organs can arise from the inner lining of a tube and of a sac, and they are quite bad cancers. As you see here, there has been very little improvement for a very long time because they are very difficult to treat. They do not respond very well to normal treatments, to chemotherapies. And the next slide is not a slide for the faint of hearts, because it shows you how there has been really very limited improvement for such a long time that at a certain point we were more or less to start losing hope, because as you can see, the survival of our patients was very bad. We estimated that about 4 to 5% of patients where the disease has gone out of a primary organ, of the stomach or the esophagus, well, only 5 in 100 of our patients would have been alive after 5 years, which is very bad. It's really sad. And again, for a very long time, we didn't see any improvements, no new chemotherapies, no new drugs for us. And luckily, a few years ago, things started changing. We started to see the first hope. And this is a brief overview of my team. So we are 5 consultants, 2 clinical fellows, 15 clinical staff. I see many team members in the audience. And we treat about 750 new patients a year. This is one of the largest populations worldwide, because for reasons related to not very healthy lifestyle, in Greater Manchester, we have a very high incidence of these cancers. These cancers are particularly frequent in this very same area. So Christie has a duty towards these patients, because we are the persons for these patients. And our team is able to welcome new treatments, new drugs, clinical trials. We will hear later from a lived experience. And this means that we are able to offer these new drugs to patients before they are licensed, before the NHS can offer them. And we do this within clinical trials. To do this, you need the support of a team, you need a lot of research infrastructure, you need the dedicated nurses, but we are able to do this. And at the Christie, we were among the leaders worldwide in treating these treating patients with these new drugs. And we contributed significantly to get the new drugs tested and approved, and now we can use them. So now the outlook for our patients has changed. It's better. However, it's still an incurable disease. So what can we do? Now that we have hope, we cannot lose momentum. And so here comes the other side of research. On one side, there is the clinical research where we test new drugs, where we give new drugs to patients to give them hope. And on the other side is to try to create new medicines, to find new ways to treat this disease, to monitor this disease. And in our team, we have I think I can group the lines of research in our team within 3 main groups. So we are very dedicated and focused on improving the quality of life of patients. And in particular, we are leading the way on new studies on anorexia. Anorexia is when a person cannot eat, cannot feel the need to eat, and they lose weight because they cannot get the food inside. And it can be very detrimental for the quality of life. And then we are focusing on discovering and creating new treatments and new biomarkers. What are biomarkers? Biomarkers are tests that we use every day. Every one of us has biomarkers done when we have our bloods taken. But some of these tests can be like fingerprints of a cancer, can tell us something more about the cancer, some of its secrets. Which are the therapies that may work on that cancer? Is that cancer responding? And all of this we aim to be able to do from a normal blood tube. And all of this research is going on the 3rd floor of a Patterson building with the blood that is kindly, generously donated from our patients. And then let's take a step back to the treatments. And now I think we enter into a science fiction realm, because we are looking at the treatments of the future here. So we partnered up with a spin-out of the University of Manchester some time ago, and we are studying new ways to treat the cancers. Let me tell you something more about the cancers. You have the bad guys, the cancer cells, and then you have the good fighters, you have the soldiers, the immune system. All of us have these cells inside us. And some of these cells, some of these soldiers are called lymphocytes. And they have a potential to kill the bad guys, the cancer cells, but they are usually too weak in this cancer to do a proper fight, to win the war. So what we did was to take a piece of a tumor from the patients who donated a piece of their cancers, and we took the soldiers out, and we did a bit of very technical magic. We engineered them to create an army. if you remember Star Wars, we created an army of the clones. And then we saw that these army of the clones with these very special engineering, very technological cells, they reacted to the tumor cells so much better. And we think that if we gave these cells back to the patient, they may be able to kill the cancer cells. So now we are working to find a way to take these out of the lab and have a clinical trial to deliver it to the patients of the future. It's gonna take years, it's gonna be long. We may not even get there, but this is what we aim to. Science fiction. Another bit of science fiction. So we are then creating a new medicine, which is a very clever medicine because it's created in the lab so that it's exactly the same, the right shape and size to get inside the tumor. And then we do some very special treatment on the surface of this nanomedicine. It has a special prongs and it can recognize very specific cells of the immune system. I told you that there are soldiers, but there are also saboteurs. So this medicine gets into the saboteurs and it changes them because it pulls the right levers and the saboteurs suddenly become good guys. They are able to kill the cancer cells. And this research, again, is going on the third floor of the Patterson. The preliminary results are really good, so keep your fingers crossed. In a few years, we may have a new medicine that is being developed here for our patients. And I was able to prepare all of this to design this project and to get funding because Christie Charity paid for my salary while I was doing the groundwork, while I was preparing this. So in a sense, this new medicine is the product of the generosity of all of the funders, and it belongs to all of these people too. And hopefully we will be able to bring it to the patients of the future. And with this, I conclude, and I hope I can conclude with a tone of hope for the future. And I will be happy to take any questions at the end.
Thanks, Sara. So I'm hopefully going to start on a happier note with my talk than you did with yours, but really fascinating to hear about your work. So as explained earlier, I'm a consultant haematologist here at the Christie. So I treat patients with blood cancer. And in particular, I have an interest in patients whose blood cancers have failed standard treatments. And so we see patients from all over the north of England and further afield sometimes where standard treatments have not worked. So I was asked to talk a little bit about my background. So here it is. I'm a bit of a homegrown doctor here, although I was born in the Cotswolds actually, so some distance from here. I did my undergraduate degree here in Manchester, quite convinced I was going to be a GP, but I seem to have lost my way. And began my specialist training in haematology in 2007. And the reason I wanted to become a haematologist was because I was very inspired by clinical trial work that was taking place in haematology during my general medical training, in which there had been a new targeted cancer treatment developed for a type of leukemia called chronic myeloid leukemia, or CML, which had turned CML from a death sentence for patients into an illness that could be managed like any other chronic condition. So you take your tablets and you remain well, and patients have a normal life expectancy. So I began my haematology specialist training, but knew I wanted to do further research into the development of new cancer drugs, and secured funding from CI UK and AstraZeneca to do a PhD based in the Patterson building, or the old Patterson building just across the road. It took a little longer than I first anticipated due to having two daughters during my PhD, but I finished that in 2016 and then spent some time sort of half and half in clinical training and doing some further work at the university. And at that point, I realised that I wanted to move away from developing cancer medicines in the laboratory, a bit like Sara does, to actually treating patients and using new cancer drugs in the clinic. And the Christie charity was key at that point in funding some time for me to come back into the clinic at the Christie and develop some skills in how to give new drugs to cancer patients. And then, having finished my time at the university and ready to take up a consultant post, the Christie charity then supported my work for 3 years to enable me to establish my clinical research team here at the Christie. And why did I want to do all of this? I've told you about my early interest, but the Christie has always been at the centre of driving forward research for patients. We have a long history in this space, and so I was very clear that really the Christie was the only place I wanted to work as a consultant. And drug development for cancer patients is a long and expensive business. But I guess one of the things that's changed, particularly over the last decade, is where kind of all the interesting and effective drugs got given in trials on the right-hand side of this, so the sort of later development trials. What we're increasingly seeing is really effective agents coming through in these early, much more experimental trials. But they're difficult trials to deliver. We have to have to have very frequent visits from the patients. We have to have a very big team to deliver those trials safely. But the situation in haematology in the UK is that London patients were able to access those drugs, but patients living in the north of England really had to travel to London or couldn't access these effective drugs that were coming through in early phase trials. And we have well, it's not quite so gleaming now, is it? But this is when it was first built. We have a dedicated clinical trials facility here at the Christie that my solid tumour colleagues were already using very effectively to be able to provide the high levels of supervision that are needed to get experimental drugs into patients. And there were also several excellent laboratory-based academic teams, a bit like Sara, but on the haematology side, here at the University of Manchester, who I knew would be able to partner with me to help develop new treatments for patients. So when I started my job, really, I just wanted to bring all of these things together to help get new drugs into haematology patients in the north of England. And I'm now, this is out of date, this photo. I can never keep it up to date anymore, but I'm assisted by a very large team now. And so I always tell patients that for every nurse or doctor that you see in clinic, there's another 5 or 6 people behind the scenes helping us to deliver these clinical trials to patients. So I wanted to now divert into one of the types of blood cancer that I treat, which is multiple myeloma. These unpleasant looking cells are multiple myeloma cells from the bone marrow of one of our patients. And the symptoms of myeloma are that the cancer fills up patients' bone marrow, so their blood counts drop. The early symptoms that might cause a patient to present to their GP fatigue, weakness, patients start to experience infections. Their kidneys can be affected because the cancer cells make a protein that clogs up the kidneys, and the cancer cells also make holes in the bones and can cause them to fracture and cause pain. So really very debilitating cancer for patients. But I said that this would be a happier presentation than Sara's because drug discovery and survival has led to increased survival in multiple myeloma. There's been a whole raft of developments of new treatments, but it still remains an incurable cancer. So it's a cancer we send away for a period of time, hopefully often years in the early stages of treatment, but it does always come back. So we need to develop new drugs to keep patients living well with their cancer. And as I said, survival is improving, but unfortunately, ultimately, most patients will die from their myeloma, and that motivates our quest for new drugs for these patients. So this is a very busy and scientific slide, but this is work that my colleague, Professor Tim Somerville, who has a laboratory over in the Patterson building, worked with a company with a novel drug called CCS 1477. This has a completely new mechanism of action. And why that's important in myeloma is because, as I said, we send myeloma away for a while, it comes back. We need completely new ways of attacking the myeloma, because when the myeloma comes back, that bit that's come back is going to be resistant to the treatments that we've given before. And work in Tim Somerville's laboratory, working with myeloma cells in dishes, demonstrated that myeloma cells were particularly sensitive to this new targeted cancer treatment. And importantly, he was also able to show that myeloma cells that had become resistant to one of the mainstays of treatment for myeloma, a type of drug called lenalidomide or pomalidomide, they're two versions of sort of very similar drugs. He was able to make them sensitive to that treatment that no longer worked on them anymore. So we were all really excited by this work. He published this work, and I was delighted then to take this drug through into treating patients. And so here's a summary of the clinical trial we've been working on for a few years now. So we twinned the drug formerly known as CCS 1477, that now has a name, inabrodib, with a standard treatment for myeloma, the one that Tim Somerville's work had shown you could recapture responses to by giving the new drug called pomalidomide. And we tested it at different dosing levels in patients to work out what was the right dose that we needed to give patients to take forward into further clinical trials, and what were the sort of side effects that patients would experience with that. And so these are just 3 case studies from patients, mainly of mine, I think, that were in this clinical trial. And the red line on this graph is with myeloma. We're able to measure the amount of cancer by measuring for this protein that the cancer cells make in the bloodstream. And so in all 3 of these patients, despite often having had a lot of treatment for their myeloma already, so having run out of standard treatments for their myeloma, we were able to see the amount of cancer decline. And these are numbers of months across the bottom here. So some of these patients have been able to stay cancer-free for years on this completely new treatment. So this was my conclusion slide from when I presented this data at the American Society of Haematology meeting. But in summary, about 3/4 of patients will respond to what we now know is the right dose of inabrodib, along with the conventional treatment, pomalidomide. And as I said, these are often patients who don't have other treatment options left. And it's importantly for patients who are going to live with a cancer and remain on treatment, it appears to be a really tolerable treatment. So I have to keep a bit of an eye on their blood counts, but that doesn't bother the patients. And in the main, they feel very well on this treatment. And this is a news story from one of my patients in this trial. She had run out of standard treatments, and this was her new grandson at the time she was referred to me. And she wanted to spend more time with her grandson, she was one of my earliest patients onto this clinical trial, and still remains on this clinical trial now, and is able to perform her grandmother babysitting duties for her grandson. Thank you very much for listening.
Oh, there. Firstly, can I say how much of an honour it is to be invited here today as a former patient. Very humbled at it, so I'll try and do my best. My name is John McGartland. I'm 61. Married to Kath, been married to Kath for 40 years. Well, not quite. We got married on the day of Live Aid, 13th of July 1985, so it's 40th anniversary this year. We've got one daughter, Helen. For 32 years I worked for Greater Manchester Probation Service. The first 16 years were great. after that, the public service changed. And for many years, I was involved in running an amateur football team. So I've spoken to many people over recent years who are also experiencing cancer, some not. And I've always begun by saying, well, don't compare me with you. Everybody's on the journey. Patients are all on their own journey. But what I've determined is that also carers and family members are also on a journey, which when I was going through my treatment, I wasn't aware of at the time. And it was only in later years that this came to fruition. And it does have its impact. My journey, take you back one. My journey started, I'm going to say, on the 1st of January 2019. The three of us went to Edinburgh for Hogmanay, and we had a fabulous time in and around the castle. It was great. Then on New Year's Day morning, we were down having breakfast, and I started choking. And it's not like a normal choke. You could almost feel as though you were drowning. It was that painful. But I wasn't too concerned, because even though it was just my normal muesli breakfast, it happened before. It happened when I was eating an apple. I had a ham sandwich and I had a plate of hot pot, and it cleared. This time was different though, because this was the first time that Kath had seen it. I hadn't told her beforehand. So as soon as we got home, contact with the GP, and the GP prescribed me with omeprazole, which I'm sure you've heard about. So I was taking that for a month, and it happened again. So to cut a long story short, I got referred to local hospital. I had an endoscopy, and then we got called back to see the doctor for the results. So three of us went in the small room with a doctor and a nurse, and it's told you've got cancer. It's in your esophagus, it's in the lining of your stomach, it's in your right adrenal gland, it's in your lymph nodes, and it's possibly in a major organ. You'll get a letter from the Christie offering you treatment, but you don't have to accept it. So I'd suggest you go home and have a think about it. So we went home, got on the couch and cried. So the letter came, and the letter to my GP said the histology reports were not available and they hadn't yet had the CT scan. The diagnosis was T4N2M1. So all sorts of questions were going through my mind, but basically, what does this mean and how long have I got? And it's at this point, I'm glad I didn't see Sarah's slide. So sure enough, the appointment letter came through. And now I try to be a positive type and not let things get me down. But when you get this news that you've got cancer, it takes it to a different level. And someone described it to me. It's an unwelcome guest in your mind, and they won't leave. And it's quite an apt description, really. So we came down to Christie, and we were filled with apprehension and no idea what to expect. Everything was new, the environment was new. And at the car park, the barrier was up. Oh, happy days. It's a sign we don't have to pay for parking. And then we were walking in, and lo and behold, there was 20 pence on the path. So, that went straight in the pocket. So we came in and found our way through to the consulting room. Met by a nurse who took some general measurements, and then I spent some time with the registrar and waited to see the oncologist, Professor Mansour, and his upper GI team. this is when my life took another turn. So, in the time we were with Professor Mansour, he explained in layman's terms about my diagnosis. Thankfully, he didn't show me the diagram, but that's moved on from that. He answered the questions in the way that we actually understood it. He also said at one point, he said, "I don't know," which for me as a patient was actually reassuring. And he accepted that I didn't want to know what the prognosis was. And this was important for us as a family, because we didn't want to be looking at a clock. So Professor Mansour told me, he said, "Well, you don't have cancer in the esophagus." He said, "You've got it in your stomach at the junction." So it was one tumour and not two. So in that few hours, got free parking, found 20 pence and lost a tumour. So as a Scotsman, I was having quite a good day. I was asked, if accepted, would I be prepared to take part in a research study using immunotherapy. He gave me a clear understanding about the frequency of treatment and what I was entering into. And it took a heartbeat for me to accept his offer. Subsequently, I was accepted and I was on nivolumab in combination with standard care treatment of oxaliplatin and capecitabine. And that day, Professor Mansour gave me hope. I'm sure you understand. So, as I mentioned, everything's new and strange. There's so much information to absorb, and faces and roles and the environment to get acquainted with. At the same time, you're dealing with anxiety that a cancer diagnosis creates. How to tell family, friends, colleagues, what does the future hold? Have you got a future? Being left with your own thoughts, and venturing into dark places. I made the early decision not to Google or read anything. I didn't want to know anything that didn't come out of the Christie. So my first day of treatment was April 2019, and that wasn't quite what I anticipated. I was sat in a chair where I was expected to be put in a bed. I was given intravenous nivolumab, and that was flushed through, and then intravenous oxaliplatin, that was flushed through. And then the chemotherapy, for my amazement, was capsules, capecitabine. And I had those for 2 weeks, and then it was a week off. And that was my 3-week cycle of bloods, treatment, scans, consultations, and the calendar was full. During the next 2 years, COVID affected us all, but my treatment remained uninterrupted. The hard work of all the Christie staff at that time continue treatment for patients was beyond a level of dedication that I'd ever experienced. The only thing that changed were the consultations, which were by telephone and not in person. I developed relationships and bonds with the nurses and doctors to whom I'll be eternally grateful. I was extremely fortunate that I can only recall being sick twice, and that was in the early stages, and that was probably down to the oxaliplatin. I was generally well, reasonably fit, and did everything that I was advised to do. I carried on working, and I tried to keep my life as normal as possible. The worst times for me were caused by fatigue, not being able to sleep, with too much time spent on my own with dark thoughts. The other worrying time, which I'm sure you may have heard before, is that gap between having a scan and having your consultation. For me, it's always a worry. You're just expecting bad news, but fortunately for me, it never came. As an aside, during the COVID period, March 20, I was referred to a pain clinic because of neuropathy, and it was particularly bad in my big toes, and they felt as though they were going to explode at any time. And it was at that initial assessment meeting with a consultant who highlighted I had a mole on the side of my temple, and I had it checked. Have I ever had it checked out? It's fine, I've had it for years, it's not a problem. Had it checked out, sure enough, it was a melanoma. Cut a long story short, I was there in January, a few weeks ago, and I was discharged. So that all worked out well for me. And going back to neuropathy, in the pain clinic, I was given something called Quitenza on my feet, and that actually worked to take away the pain. So now I just have the mild neuropathy, but without the pain. Just before Christmas 2020, I received a telephone call, from Dr. Sheen, one of the doctors is in regular contact with. He personally wanted to let me know that I was in remission. I can't describe the emotion that followed. And the drugs had cured me. Saved my life. Quite feeling. I asked if I could carry on and see out the last few months of treatment, and that was agreed. And it gave me the opportunity to ring the bell. And whoever came up with that notion of ringing the bell after treatment, my God, it's just what it does to you. Amazing. Excuse me. Last week, I came in to have my bloods for scan, and I picked this up. Never seen it before. It's not unusual because it was the first edition, and and there's an article in it by a patient that's 100% applicable to me, and I'm sure many other people, and relays the feeling that I have for the upper GI team that Sarah's part of. And this patient writes, Richard sees me as a whole person, not just a person with cancer or a set of symptoms. He takes time to really listen to me without any rush, hearing not only what I say, but what I don't say. This makes me feel he completely understands me. This is what staff at Christie's do. Very good at it. Although the cancer appeared to have gone, there was no guarantee that it wouldn't come back, in which case I was in a lot of trouble. Professor Mansour, through discussions with a multidisciplinary team, gave me the opportunity to have my stomach removed. And again, for me, it wasn't an option, and I accepted it. So on the 12th of July 2021, day before my wedding anniversary, if you're also paying attention, at Salford Royal, Dr Alan Lee performed a full gastrectomy to remove my stomach. The procedure went well. On the downside, the sleep in hospital is horrible. And this was a picture of when Kath and Helen came to see me. Not having a stomach has left me with some lifestyle changes. I can eat whatever I want, but in smaller proportions. I can drink a couple of pints, whereas in the past I probably had a couple more than a couple. I play football twice a week. I go for long walks, and neither the neuropathy nor the gastrectomy has prevented me from doing anything that I want to do. However, I'm also mindful that I'm under the watchful eyes of Kath and Helen to keep me in check. So here I am today, as normal as I've ever been, living a full life, but my story doesn't quite end there. On the 13th of July 2022, I received a message. "Hello, John. I'm your wee cousin Elaine. I was found by a family that I didn't know I had. I had 3 aunts and 8 cousins, so we made the immediate decision to go up to East Kilbride, just outside Glasgow, to meet them, and our relationship has bloomed ever since. Then East Kilbride, Glasgow, Isle Harris, the Highlands, Essex, California, Toronto and Perth, Australia. And since the initial contact, we've seen, I think, virtually everyone except one cousin still got to meet. And this was us last year in Perth, Australia. We went as a big family holiday over to see one of the cousins over there. Now, I believe that the timing of our meeting was fated, that they found me after my diagnosis and after my treatment, and I was cured. And they didn't have to suffer all the pain and the torment that Kath, Helen and me went through. So, that's my journey. After a bumpy start, there was a smooth middle and a very good end. On the way, I've met so many wonderful, compassionate, professional and dedicated NHS staff. If it wasn't for them and the staff behind the scene, who are just as important, if it wasn't for the amazing researchers, if it wasn't for the drugs, the surgeons, the list is long. I probably wouldn't be here. I must also mention the fabulous work for cancer charities, including Macmillan and Maggie's, and numerous volunteers who help cancer patients and their families. What it's done for me, my family, I can't put into words. The advancements made in the treatment of cancers are truly incredible, but it's only possible if resources are made available to continue the research and allow these wonderful people to be part of so many more wonderful stories. Thank you.
Wow. John, thank you so much for sharing that with us. I think the honour was with us to hear your story and for you to share that with us in that way. Thank you. And thank you also to Emma and to Sara for your superb presentations. I think many people in this room will be able to really empathise with the highs and lows of your journey. So thank you so much. So how do we follow that? Well, with Q&A. So please, if anybody has any questions they'd like to ask of any of our panelists, please raise your hand. First question here with the lady with the scarf.
Hi, I have the question to the first speaker, Sara. Sorry, I wanted to clarify what kind of immunotherapy treatment was it, and has it been used for any other cancers as well? If you could go into more details.
So, immunotherapy is currently in use for upper GI cancers. John had one of the drugs. What we are trying to develop is not already in use for other cancers, because we tailored these 2 immunotherapies to upper GI cancers, because we studied the esophagus and the stomach cancer cells, and we saw that they had certain characteristics that are not shared by other cancers. And the medicines, in the first case, the army of clones is specialized to recognize certain characteristics that are on these cancer cells. And in the second case, the nanomedicine, the new medicine, doesn't recognize the cancer itself. It recognizes immune cells to make them better fighters against cancer, but the characteristics, like the physical properties of a nanomedicine, how gummy it is, how tensile, how big it is, that is designed specifically to enter in the best possible way inside the cancer of the esophagus or the stomach and stick in there. So these two new treatments are designed for tumors of the esophagus and the stomach. It would be possible to then tweak them for other cancers, but at the moment we are taking a very specific and focused approach.
Thank you, gentleman with the microphone.
Thank you very much for really interesting presentations. I noticed in both of the presentations you talked about working with private sector companies, and obviously you're using both money from charity and from the UK public sector. How do we make sure that the treatments that you develop are actually available to UK patients, and that NICE doesn't turn around and say that the treatments are too expensive after the end of the research process?
So big clinical trials or early phase clinical trials are very often led or at least in partnership with the private sector, because at the moment, at least in this country, we do not have the firepower as academics to lead on the drug development. We simply don't have the infrastructure, the people, the know-how, and we cannot do it. So it's an approach that can have its drawbacks, but it allows us to develop the drug. When we take money from the private sector, the terms and conditions are usually very strict, specified by a contract. So, for example, every time Christie agrees to partner up with a drug company for a clinical trial, there is a very long contract that goes through many rounds of view and approvals with the lawyers. In my case, for the first drug, it's developed with in partnership with the private sector, but what we are trying to do is to find an agreement so that we can develop it, and there is how can I say that, and the company agrees to then move it forward. In the second case, has no industry input, it's entirely academic. To be honest, I do not know if at a certain point we will need to partner up with industry or not, but at the moment we have a complete freedom, and what we want is to give it to patients. So what you observe is real, but it's us clinicians that safeguard. And we are usually pretty careful in the decision, whom do we partner up with? Do we trust these people? Is this something that then is going to be given to patients or not? Usually companies have a very big interest in commercializing the medicines. So it's a negotiation. This is the bottom line. It's a negotiation. One of the advantages of keeping research in academia is that then you can set your rules. So you can say, we don't want this drug to cost too much. We don't want this drug to go only to certain people. And that is one of the great things of being funded by somebody who doesn't have any economic interests and only the wellness of your patients at heart. So I feel very privileged because I can operate with complete freedom.
Go ahead, sorry, Emma.
Yeah, I was just going to add briefly to that. I think that was covered it, really. And I think, as Sara said, the reality is we need to work with industry to press the kind of go button on making a drug that is of a standard that we can put it into a patient. Is enormously expensive. And so we do have to partner with industry. And it can be a rewarding experience in itself, actually. But when it comes to getting things past NICE, absolutely it's frustrating if stuff gets turned down by NICE and we lose access then to those drugs that we've been helping to develop. But by being able to attract those, to run the early development trials of those drugs and then work with the companies from an early stage, the more rewarding companies to work with will listen to us about the types of trials that they need to do to stand the best chance of getting NICE to approve the drug. And certainly for some of the agents that we've worked with in recent years, NICE has consulted experts and inverted commas in using those agents as part of their process, and we have seen some of them come to the UK ahead of other countries in the world, actually. So yeah, it's a balance, but I think the reality is we need to partner, and we do get some of these drugs all the way through.
Yeah, thank you. Do we have another question? Yes, this gentleman here, please, and then you next.
Thank you very much. Good morning. Thank you very much for a very interesting couple of presentations. Question for Sara. You've got on nanotechnology and you have got an immunotherapy drug. Can you give it to another patient, and would there be any benefit from that?
The answer is I don't know, because I've not done it yet. So if the studies go ahead, I'm sure we will get to test it sooner or later, and then we will know. But there is a good, let's say that there are good probabilities that these drugs can be touched up to work for other cancers. And I hope we will get there, because there's good reason to think they should work. Testing.
Mine's a cross-section, really. My husband was going to the doctor with a swollen throat, and he was diagnosed with antibiotics for the swelling. I'm trying to condense this. He had just happened to be going to the dentist, who was very lucky. They found the lump under his tongue, and he had mouth cancer. So the journey was that he ended up under 5 hospitals. One of them was Christie's, Mr. Patel, which was excellent. Maxillofacial reconstruction. He had both sides of his jaws replaced with his hips. Lots of surgery. He had his birthday when he was 65 in the December, and unfortunately passed away in the January. But when you were talking about lifestyle in the Northwest, my husband did smoke. It was the in thing to do when he was younger, and he did like a drink. But also the family, the gentleman, I've forgotten his name. I do apologise. The knock-on effect with the family, I became the breadwinner and the carer. So I just wondered what package, the support package going forward for other people going through. I mean, I've been a widow since 2008, and I'm very independent. But I just think for the future, the surgery and all the, like the gentleman said, around the patient, but the knock-on effects I don't know how to, is there something, because I was so independent, I didn't ask for help. So, anyway, thank you. I'm not sure which one of you, I think all three of you are in this, what I've just been saying.
Yeah.
Thank you. Thank you.
Thank you for sharing. I totally agree with you and John that very often the carers are the unsung heroes because we don't see them. Sometimes they do not even come to clinic accompanying the patients. Certainly they were not coming to clinic during the pandemic, and they carry a huge burden. And very often we doctors focus on the patients, but you point out a real problem. So I hope moving forward, this is one of the things that can be taken into account to improve the way we treat the families as a holistic entity, not only the patients. And there are some services that are available to families. There are some support networks that are available to families, but you certainly highlight one of the indirect impacts that this terrible disease that cancer has to people. And let me just stress that when I said that there is a high concentration of these cancers due to not healthy lifestyle, it was not meant to be like to make a lifestyle guilty. It's just an association. We have this high concentration of people who smoke a lot. Very often they also drink a bit too much, and every person comes from their own journey, and whatever happened before the cancer started has already happened. We know that there is an association. It's not guilt, so it's not a fault. It's just an association that we see, and the result is that unfortunately we have a lot of patients.
I understand that, but what I can't understand is how the doctor just gave my husband antibiotics. If it wasn't for the dentist, he'd have gone a long time earlier, so and also I don't know whether the Christies go into schools or anything like that. With the lifestyle you were saying in the northeast, I just wondered if, perhaps going into schools or something like that would help. I didn't ask for help, so I just so that's just one of the things. I just was like, the road runner sort of, just trying to balance all the balls, really,
I cannot comment on your husband's journey because I do not know the specific situation, so unfortunately I think none of us can comment on it. And there are initiatives. Some of them are in partnership with Christie, some of them are led by Cancer Research UK. We have a very close tie with the teams. It's a very harmonious collaboration. So certainly improving and giving the opportunity to people to improve their lifestyles, and also giving the tools to improve the lifestyle is something that is being taken into consideration, and there is some work going on.
Last one. Squeeze this one in.
Thanks. I'd like to just address a comment to John, if I may. I want to make sure, John, that you appreciate the value of what you've done today, coming here and talking to us about your journey. I'm a member of staff at the Christie. I don't normally get to work with patients. I work with computers and data. So listening to your story this morning is incredibly motivational for me. It reminds me why I get out of bed in the morning and make the journey to come here. You've given me the motivation today to keep doing that indefinitely. I mean, I can't ever see there being any end to it. Thank you very much for coming here and giving us your story.
Thank you, I appreciate that, but generally it's me that needs to thank you all. Thank you.
Oh, what a wonderful way to end. Thank you for that comment. And I think it really does just highlight the power of these events. So thank you to everybody at the Christie and the Christie charity that does all the hard work to make these events happen. But thank you to everybody for joining us for these events. Thank you for all the ways that you show support for the Christie. And thank you in particular to all of our panelists this morning for sharing each of your perspectives on everything that you're doing. We're incredibly grateful. And please do join us for the next event. Look out for when we publish the timing for that. Thank you very much.